welcome to the Home of Medicine podcast, a podcast in association with the Royal College of Physicians, Edinburgh. I'm your host, I'm Dr. Amie Burbridge.
And I'm your other host, I'm Dr. Ben Lovell. And I just wanted to say, before we dive into our case for today, welcome to anyone who's listening for the first time. And if you're wondering what you stumbled across, this podcast, Home of Medicine, is a podcast that is completely unscripted. And when we turn up to record, neither of us have any idea what the other person's going to do or say. And what we do is one of us brings a case, one case per episode, and we present it bit by bit. And the listener and you at home work through the case as we're presenting it, and you try and work through the diagnosis as we do in real time. And the purpose of this is we really wanted to show how consultants think. Because particularly when you're training in medicine, sometimes consultants come out with plans and ideas and you think, how did they get from A to B? And we wanted to make those thought processes explicit. We wanted to talk about clinical reasoning. We wanted to talk about diagnostic uncertainty and just how we navigate those pathways and come to the ideas and the conclusions that we do. And as you will learn, how consultants sometimes get it wrong. So we're not holding ourselves up examples saying you should be like us. We just want to show you this is how people who've got 20 years of practicing medicine under their belt work through clinical cases and patient care to the end result. And we hope you enjoy listening along and trying to guess the diagnosis with us. And on that note, it is your turn, I think, to present a case to me.
Absolutely. So I found this a really interesting case. It's a case that I've seen within the last year. So it's quite fresh in my mind still because, to be honest, I'm still working through the process of what happened. So I saw a 64-year-old female. She came to hospital via the emergency department with confusion. Now, I know that confusion, we've discussed it a lot, and it's a very common presentation in hospital. Now, I took a history from her and her husband. Her husband was sitting there. And initially, I didn't think she was confused, actually, when I saw her, although the emergency department initially said that she was. On further questioning, she said that she was very tired and she'd been tired for around 24 hours prior to admission. But she said she had no other symptoms at all. And I asked every single symptom and she denied it. However, after she'd been in hospital for about 12 hours, she had urinary retention. She had a distended bladder. It had over 1,000 mils of urine in the bladder. She was treated with antibiotics because it was felt that actually the confusion was because of a urinary tract infection. She'd gone into urinary retention and she was also constipated. So the initial working diagnosis was urinary tract infection, constipation, and the management is going to be antibiotics and laxatives. I'm going to stop there.
For constipation. This is me taking notes. Not that it helps me think, but 64-year-old with confusion. We talked a little bit on a recent episode about delirium and UTI delirium, which is an incredibly common phenomenon within acute medicine, either as a correct diagnosis or as a kind of a diagnosis because we can't think of anything else. So let's call it a UTI and confusion and treat based on that. And we talked a little bit about the knee-jerk reaction to prescribe a bit of nitrofurantoin or some trimethoprim for confusion in older adults because why not? It might do good and it won't do harm. And we both expressed a little bit of unease with that approach because it means there's a heck of a lot of antibiotics flowing out there in the acute medicine world which maybe aren't needed. And one thing I remember saying was, how old do you have to be to have a UTI with delirium? And there absolutely isn't a cutoff age. To get delirious with infection, you just have to have a vulnerable brain. So someone who maybe has had a previous cerebral insult, like a stroke, or they might have a mild form of dementia or early memory loss, which could then turn into a dementia process. And all of that being said, 64 to me is quite young. And you can get delirious with a UTI at 64, but usually in the context of someone who has other illnesses, and it doesn't take much of an acute insult to develop into a delirium. So that's my thought. And I just thought that down when I was writing down her age. Um, I'm not quite sure about the antibiotics in this one because you've said she's gone into urinary retention and then you told me a good reason why. She's constipated. And constipation is a really common cause of urinary retention in older adults because of the pressure from if you have fecal loading in the rectum can squeeze the outlet of the bladder and the urethra and then they can't pass urine. And usually catheter, a bit of fecal disimpaction with laxatives and maybe something PR. And then once they've had a good bowel movement, you can take that catheter out again. So I'm quite intrigued why antibiotics were gone for, why people thought, oh, this is a UTI. Because UTI can cause urinary retention as well. You get inflammation in the urethra, it closes up, they can't pass urine. But you seem to have a really good explanation for the urinary retention. And urinary retention is a cause of delirium. So within that sort of self-contained sort of very, very limited history, is this someone who got severely constipated and the constipation plus the urinary retention due to the constipation caused an acute episode of confusion and all they need is some disimpaction, getting their bowels going, getting the bladder emptied and things would sort of melt away and they go back to baseline again. But I'm wondering if you had some other really good evidence for infections such as a fever, dysuria, and elevated inflammatory markers or anything like that. That's my initial reaction.
Okay, absolutely. And to be fair, that is exactly my sort of thought process as well. Now, as I say, I was talking to her and her husband, and it was quite it wasn't, and I don't like to say difficult to take the history. There was a lot of talking from both, which is fantastic, but it's sometimes therefore you have to really focus in on what is being said and truly listen, which can sometimes be challenging in a very busy, very loud acute medical unit. There is always noise. As I said this before, whenever I'm with a patient, the hoover's going, or the cleaner that cleans the floors, that big machine. There's beeps going off, there's phones going off, there's shouting. And I don't know whether it's the older I get, but I'm having to really try and close out that external noise. But it's really made me think, trying to make these decisions when it's so loud, be really challenging. So it's very loud, but I asked the questions again and I identified, and she said that she'd been lethargic and actually she was unable to move her legs.
Oh.
She said that her legs felt very, very weak and there was a lot of pain in them. And this pain in her legs had been building up for 2 to 3 weeks, which wasn't really responding to any pain relief. The pain was located around her calves, her ankles, and her knees. And as I said, she couldn't really lift them. She also, on further questioning, said that she had some pain in her lower abdomen and her back. And it was the lower back as well. It was like the sacral iliac region. She did say that she was constipated and hadn't really had a good handle of her bowels for around 12 months. So this constipation had been on and off for around 12 months. She also said that she was sleeping all the time. She was finding it easy to get to sleep and she was able to sleep. She might wake a couple of times in the night to go to the toilet, but apart from that, she was sleeping well. She wasn't eating as much and she'd noticed a little bit of weight loss. But the thing that I noticed when I was talking to her, she was anxious, really anxious. And was the anxiety because of being in hospital and the noise? Because I have to say, sometimes I feel the noise can really affect me. And her husband also said that actually she was very anxious and they were really worried about the anxiety. And on further questioning, she said that around a year ago, she started to believe that there were 2 men on the internet who were trying to take her house, her sister's house, and her family's house. She was started on risperidone. She'd been seen by the crisis team, and it was felt that these were delusions. She truly believed that there were two men on the internet, and I asked her to describe them, but she couldn't really describe them very well for me. She said there was a big man and a smaller man, and they were talking to her all the time. And her husband said to me, "Oh, they've all gone now, that's all sorted." And I said to her, when was the last time these men spoke to you? She said, "Oh, this week, they're still talking to me." And I was like, okay, so now we've got a patient who was constipated, leg weakness, but now there's this additional symptom of two men talking to her on the internet. Now, I find this difficult because actually there are a lot of people out there, a lot of on the internet who may actually have been doing this. So how do we know whether this is real or not real? And so at this point I was like, I have no idea what's going on.
You were a little bit more interested than I would have done about these. Describe these two men. I don't think I would have gone in that much detail. Oh gosh, I've written down so much stuff.
Okay.
At the moment, a unifying, satisfactory single diagnosis is eluding me. I'm going to just compartmentalize it into bits.
Okay.
And number one, you say leg weakness. For how long did you say? Sorry.
2 to 3 weeks.
Okay, leg weakness plus urinary retention, that localizes to the cord. Has she got cord compression? Has she got cauda equina syndrome?
Okay.
She's got sphincter dysfunction and leg pain and weakness. So do we need to think about cord imaging?
Yeah.
That's thought number one. Thought number two, potentially a cord lesion on the background of not eating or drinking very much and losing weight. Is this a new cancer? Which somewhere, a metastatic malignant process potentially with spinal mets, which is causing cord compression. That sort of ties those two things together. So I need to do a really thorough neuro exam of the lower limbs to see whether this rules in or rules out my idea that she could have cauda equina, which has led to the urinary retention and to the leg pain and to the leg weakness. Not eating, losing weight, anxious, sleepy all the time. Well, somnolence is a side effect of risperidone, but she's been on that for a year and she's been feeling tired for 24 hours. So unless she cranked up the dose or took a bit too much of it in the last 24 hours, we can't blame the sleepiness on the risperidone. Again, we could blame it on some kind of malignant process, paraneoplastic process.
Yeah.
So that goes over there. And then metabolic stuff, I think we probably need some bloods. Are we interested in calcium levels? If I'm thinking about bony destruction, bony mets, cancers, I ought to do thyroid function. If she was profoundly hypothyroid, I mean, that could cause confusion. It could cause the somnolence. However, she shouldn't really be losing weight. So
Right.
it doesn't quite go, but I definitely need to get some thyroid function tests here. So my plan at this point would be a really good neuro exam, looking at the lower limbs particularly, and getting some blood tests looking at her metabolic function and endocrine function, see if she's anemic, any other signs of a sort of smoldering malignancy, which might raise a flag for further investigations.
Okay, excellent. So I will talk you through those then. So just before we move on to that, her past medical history, I forgot to mention, is hypertension,
Mm-hmm.
hypothyroidism,
Ooh.
and she'd had, in her teens, she'd had quite significant mental health problems, and had been diagnosed with depression and anxiety,
Okay.
as well as the episode a year ago where she'd been under the crisis team with her delusions.
Yeah. Yeah.
So on examination, her respiratory rate was 16, oxygen saturation's 99% on air, blood pressure 152/73, pulse 64 beats per minute and regular, temperature 36.5.
Okay.
On examination, her heart sounds are normal, chest was clear, abdomen was soft with some tenderness in the suprapubic region. So, neurological system. First of all, I looked at the upper limbs, and the power in the upper limbs was 5 out of 5. It did feel, however, that the tone was increased in her upper limbs, which was a bit unusual, but I don't know whether that was just me. And I also noticed a bilateral fine tremor in both hands. The reflexes are present and they were normal. Now, when we went into the lower limbs, I found this quite difficult to assess, primarily because she was unable to do much because she said that pain was so bad in her legs and she said she couldn't lift either leg. So I tried to lift the legs, but she was unable to keep them up within the air. So not a great examination from my perspective. Tone was normal. Sensation was intact in the lower limbs.
Mm.
So
Who was normal, you say?
tone was normal, absolutely. Cranial nerves were normal. Completely normal. At the time I saw her, she wasn't confused and her GCS was 15/15. I was unable to assess her gait because she couldn't move her legs. I also noticed 2 bed sores as well on her bottom of her back and her bottom, which to me would indicate that she'd probably been in bed for longer than 24, 36 hours. Absolutely. So I have to say the neurological examination didn't yield much for me, apart from the upper limb was normal and the lower limb, as a combination of pain and possibly weakness, there was bilateral weakness at that point. She was very emotionally labile. She was crying and anxious, then all of a sudden was very calm and settled.
Mm. Sorry, did you say her lower limb examination, the power was?
I would probably put it at 3 out of 5.
So what
Bilaterally.
you did have, like, okay, fine. And okay, you said maybe slightly increased tone in the arms. I'm just thinking, we got upper motor or lower motor signs here? Reflexes and plantars?
Planters were normal and reflexes were normal.
Okay. And tone was maybe a bit up with a tremor in the upper limbs, but was normal in the lower limbs, but the lower limbs had weakness, which sounds like a lower motor problem. Well, of course, cord equina does give you lower motor
Yeah,
symptoms. Like,
absolutely.
I'm still thinking about an MRI of the cord at this point, because there's one unexplained weakness in the legs with sphincter dysfunction. So I think I still am going to do an MRI imaging of the spine at this point, lumbosacral spine. Anything else that's going on? Has she taken too much risperidone? Well, she could have malignant syndrome, but she ain't febrile. Her tone is a bit decreased, but she's not got super high tone. A CK might be useful here.
Yeah.
But it would cause the tremor. So I would just make sure she's not accidentally overdosed or intentionally overdosed on the risperidone. Is she taking any other psychoactive medications?
So medications at the moment are levothyroxine,
Yeah.
amlodipine, mirtazapine,
Oh, okay.
so atorvastatin, levetiracetam,
Right.
paracetamol, nortriptyline.
So there's quite a few sedating drugs actually. Mirtazapine is very sedating. We actually give it to people with depression, with insomnia at nighttime to help them sleep. Nortriptyline, absolutely. And what's the other one you said? Oh, Keppra, levetiracetam. So all of those taken in excess, yeah, that'll be interesting actually. Is this actually a case of toxicity? So I would want to know how she knew she was taking her medications appropriately, because that would cause a few things. The anticholinergic effect of the mirtazapine and the nortriptyline could put her into urinary retention. So that might work with that as well. So I want to make sure she hasn't accidentally or intentionally taken too many tablets. And I did have another we've already mentioned thyroid that we're going to check as well, and her blood tests you're going to tell me in a minute. And that's where I'm sitting at the moment.
Okay. Do you know what I did? That would be good if you did.
End of case.
Problem solved. No, I saw the increased tone and rigidity in the hands. And I said, has your writing got smaller?
Okay.
And it was that classic case of trying to make a diagnosis fit the signs. And I was like, oh, she must have Parkinson's disease. Oh, my word. I'm great. I've diagnosed it. Well, needless to say, she probably doesn't. But that was in the moment when I examined her hands and noticed that rigidity. I was like, this is cogwheel rigidity. This must be Parkinson's.
And of course, she's on risperidone, which is an atypical antipsychotic, and that would include Parkinsonism. Okay.
Exactly. So that was where my mind went. And as sometimes you get, when you think of a diagnosis and you think, oh, that's a good one. And then you sort of stop thinking about other diagnoses, which is what we call premature closure when we take histories and examine patients. But so that was in my thought process. And I'm not saying that that's the only diagnosis that I came up with, but that's certainly the route that I took. So you wanted some blood tests. So her white cell count was 16.6, neutrophils of 13, sodium 140, urea 6, creatinine 60, CRP less than 4.
All normal. Okay.
Yeah.
Any bone profile or thyroid function at this point or not yet?
Not done yet.
Okay.
No. But her platelet count was slightly elevated, actually, at 564. But apart from that, everything was normal.
Okay. The only other thing, when you said, I forgot it to say at the time, I remember now, when you said emotional ability, you see that with neuron disease, and she's got a mix of upper and the neurology symptoms.
Good thought.
So that's the other thing. I just have a vivid memory of when I was a first-year medical student in Newcastle. And in between lectures, they brought a patient in to take a history, so to talk about disease. And it was a man with motor neuron disease. And he was I remember he just cried, and then he laughed and cried and laughed during the consultation. We were all 18, 19-year-olds. We hadn't seen any medicine yet. We all found it very shocking. And I remember when he left the room, the lecturer saying, you notice the emotional ability. It is a hallmark of ability. And that stuck with me for 25 years. Anyway, just a thought. So what we're going to do now then, I still probably would think about cord imaging here and a neurology review. And I really want to nail down, is she taking her tablets as prescribed? Is there a dosset box I can interrogate or anything like that?
Good thought. I didn't ask about a dosset box, actually. The their husband said that she was taking a medication, but, whether that was the case or not, whether the patient was actually taking them is another question. It's very difficult, isn't it, to really know about compliance. But yeah, good thoughts. So you need to tell me what your next step is. You said you want to do an MRI.
I would, based on that information, if she's telling me that her legs are weak, they look weak on exam, and she's retaining I want to see what's going on with her cauda equina. So I'd do that first, and I'd admit her for that test and also for observation and probably a neurology review as well. If that MRI came back normal, I probably would start thinking about, should I look for cancer here? Do I need to do a CT abdo-pelvis as a sort of a cancer hunt, as a malignancy screen, and see whether there's a malignant process going on here, as well as get the LFT's bone profile and thyroid function at the same time? And if that revealed no results either, then only at this point would I probably start thinking about getting asking our mental health liaison team, our liaison psychiatry team, to offer them to say whether this is something that could all be underneath the structure of some kind of depressive episode with delusions, which she has got a history for. But I don't really want to call them yet until I've worked her up.
Yeah.
From an organic point of view.
Okay. So my note that I'd written was similar to what you said, actually. The unifying diagnosis is unclear. Presentation could be an underlying psychiatric condition. However, I'm really worried about these Parkinsonism symptoms, which could be related to drug-induced. Or is this, as you said, cauda equina? But I also wanted to do a CT head, just to have a look what was going on. But the first thing that she had done, her MRI spine, showed no significant disc bulges, normal vertebral alignment, normal marrow signal. The only abnormality is a pre-sacral fluid collection.
Oh, that stumped me.
I could tell you actually looked stumped. It stumped me.
Fluid collection.
Yeah. Like 3 centimetres by 6 centimetres.
3 by 6.
No, sir.
Causing any neural compromise or compression? Did they give a punt about what it could be?
No, And it just said there was no ovarian mass, but they didn't comment anymore. They said there was no evidence to suggest discitis.
Is this a coincidental finding or is that
Mm.
causing problems here? It's a bit of a coincidence. She's got a mass in her sacrum and then she's also got weakness of the limbs and she's gone into urinary retention. I wonder what would make this look clearer. A dedicated MRI pelvis potentially? Do we need to give the gynae team a call? I'd have to have a think about how I'm going to investigate that because it seems a bit too coincidental for me to pass. Oh gosh, what an interesting incidental finding unrelated to presentation. It seems to be involved somehow.
It's really complicated, isn't it? And she had a CT abdo-pelvis, as you suggested, and it showed no evidence of malignancy at all, apart from the pelvic, this sort of presacral collection.
And did they call it a collection on both MR and CT imaging? They called it fluid collection.
They did.
They didn't say abscess or anything.
No, it was collection.
Mm-hmm.
Mm.
Sacral collection. Collections need to be aspirated and analysed. How are we going to get to it? It's not going to be with me, with the old physician. So pre-sacral, it's a pelvic phenomenon. I probably would speak to gynae actually and say, is this something you've seen before with endometrial pathologies? Is this something that could be amenable to some kind of aspiration? Is it something that could be amenable, worth doing some kind of ultrasound, like a transvaginal ultrasound, just to try and image it clearer? She's got no signs of infection, right? Her CRP's low, she's afebrile. It's not as if she's had PID, which has developed into a walled-off abscess or anything like this. It would be very strange. You said she's got suprapubic tenderness, but she's not someone who's said she's had any signs of a chronic gynae infection in terms of discharge or pain. So that might be my next port of call.
Okay. Yeah, I agree. I'm just going to throw something else in there now.
Oh, well, no more. Go on.
So, CT head was done.
Yeah.
Which showed a large left frontal intraparenchymal hemorrhage.
Large left front. Okay.
With vasogenic edema.
Right. In many ways, that's quite straightforward, isn't it? You get the neurosurgeons on the phone, and I've noticed in the last couple of years, if they have vasogenic edema and some mass effect, even with a bleed, they do actually recommend dexamethasone now. But traditionally, you only gave that with solid masses, and that actually might help take some of the heat out of the vasogenic edema and actually improve her cognitive function a little bit and wake her up a little bit, make her symptomatically improve. Why has she had no head trauma, has she?
No.
A spontaneous so it's hemorrhagic stroke essentially.
Yeah.
A spontaneous intracerebral intraparenchymal bleed is a hemorrhagic stroke, which is a rare form of stroke because most strokes, as we know, are ischemic. So do we speak to Hasu? Gosh, I'm making a shopping list of people to call here, and I don't like doing things on my own. Her clotting is okay. Her platelets is slightly high.
Slightly high. Her INR, prothrombin within normal, and she wasn't on any antiplatelets or anything like that.
So at this point, I'm thinking about who am I going to call for the head? I'm going to be probably ringing stroke. That is what they're there for. And would they recommend anything like a CT angiogram to look for a bleeding point? Obviously, it's not one for surgery because you can't operate on a diffuse parenchymal bleed. It's not like there's one bleed which can come out in a burr hole. And she's going to need careful neuroobs in a HASU environment, hyperacute stroke environment, because careful blood pressure monitoring and all that sort of thing. A swallow assessment, a careful physio assessment. But I tell you what, an acute brain hemorrhage should not cause bilateral leg weakness.
Exactly.
Because it's a hemispheric. What side did you? Oh, left. So it should have caused for her right-sided, right-sided neurology. So it doesn't tie in with her presenting neurology at all.
Exactly. So initially, the response was, "Oh, we've got a diagnosis. Yeah, we've got this. Yeah, we know what's going on." And I was like, "No, because that they're not linked. Like the legs and the CT scan findings aren't linked. The MRI was normal. What about this presacral collection? What is this? There are so many things going on now, so many. And I think when you have so many diagnoses like this or so many problems, you can get lost, can't you? You can sort of not entirely sure what's going on. And I find it really helpful. We do this quite a bit to now write exactly what are the problems and what we found in black
Write it
and
in
white.
notes, you mean?
Yeah, in
Oh,
front.
yeah, I completely. And do you know what? You have to write it yourself. Do you not find?
I mean, I still write with a pen and paper at work. So even though we've got electronic patient records, I still use a pen and paper to do my problem solving. But I find that typing for me doesn't give me that cognitive space that writing on a piece of paper does. And I know that's personal to me. So I will write it down and I will go through what the problems are, what my investigations are, and then trying to think of different diagnoses or unifying diagnoses and trying to put it together like a puzzle. Because I can't do puzzles on a computer. I'm still doing my Sudoku on paper. So, when it comes to problem solving in medicine, I have to do it on paper. I'm very old fashioned.
I don't mind doing it. We don't have paper notes. We like you, we have electronic notes, and I don't mind typing it out. So that's fine. But I've got to do it. And when you're on a ward round and you're with a nice resident doctor, and you have to say, "Look, can you shift it out the way, please? I need to do." I can write that down. What do you want me to say? Is that I've got to write it because it helps me think.
Exactly. Me too.
And goodness, they must be bored just standing there watching me, two-finger type at a computer very slowly for about 10 minutes. But that's the only way. And then at the end, I go, right, and then problem 4, and then problem 5, could be related to problem 3, need to this. And I go, right, I think I've worked it out now. I've done it. Sorry, that was really boring for you. But if I dictated that to you and you typed, it wouldn't have gone through the right pathways on my brain. And also, I don't like dictating to resident doctors like they're stenographers, or it's not what they're there to do, really. I'd rather just say, we have these computers on wheels, and I say, turn it around to me. I yank the height up because I'm always a foot taller than everybody else. And then I say, I just need to type this out myself. No, delete that line. That doesn't make sense. Oh, that needs to be cut and pasted over here. And then, even if at the end I still haven't got the diagnosis, so I've achieved something. I'm like, at least I've got this sorted in my brain. So now I know where the problem sits. Whereas before, I just felt a bit lost and helpless. And like I wanted a biscuit and sit down and a cup of tea, which isn't useful for the patient.
Yeah, I do exactly the same thing. But what I found, apart from I write it on paper still, what I find helpful at the end of that is to then I'll write problem representation and I'll write 2 to 3 lines to unify the whole thing. And I'll talk about it, whoever's I'm working with that day, and I'll ask them for ideas. So trying to make decision making just like team thing, and sharing my ideas and getting their ideas. And sometimes they'll say something, I'm like, that amazing, yes, write that one down, very good. Because it's something I just haven't thought about. So I find that really helpful.
Though it takes a lot of time. I've always got one I say, oh gosh, I'm really falling behind here. I hope the next 3 patients are all straightforward.
Yes.
So Romeos or something, so I can catch up. You have to really step out of your, out of the moment and take the time to do it.
You are stepping into your type 2 thinking, your slow thinking.
Yeah.
And as doctors, consultants who've had lots of experience, we practice type 1 thinking, fast thinking, pattern recognition. To step out of that and consciously go into type 2 thinking, that takes cognitive bandwidth and it takes time. And for me, it can sometimes take 20 to 30 minutes for me to really get into that space and really think properly.
Yeah.
And we all know that time is a very precious commodity. So it's trying to utilize that. But in this case, I think I probably spent from beginning to end around 1 hour because it was so complicated for me and I just needed that space to really think about it.
Yeah.
So at the moment, we've got a CT head, which shows an intraparenchymal bleed. We've got an MRI, which shows a presacral collection. We have a slightly elevated white cell count and neutrophil count with a normal CRP, and we have a background history of delusions that she'd been under the care of the crisis team recently, within the last 12 months, which had now settled. What do you want to do next?
You're looking at me expectantly like I'm about to say something intelligent. What do I want to do next? The only thing I was thinking of is we keep saying, I can't work out the unified diagnosis. Do I need one?
Exactly. There
She-
probably isn't one.
She might have 2 or even 3 separate pathologies which have
Exactly.
converged at the same time. And I'd hate to waste a lot of brain time going, how can I force a sacral collection to fit with it? So, I mean, it may be she's had this sacral collection for a long time and it hasn't bothered anyone at all. And she hasn't had any symptoms. And then she's acutely, separately to that, developed a spontaneous bleed, hemorrhagic stroke. The leg weakness, I don't know. But I'm just thinking that maybe it's not going to fit into one satisfying diagnosis here.
And do you remember Hickam?
Yeah, of course. But tell me, go on.
Hickham's dictum.
Yeah.
A patient can have as many diseases as they damn well pleases.
Yeah.
And I think that's really, we often think about the one unifying diagnosis, Occam's razor, but actually now multimorbidity, complex medicine is way more common than having one condition that explains everything. So I agree with you. I think this patient's probably got 2, 3 or more conditions without one particular unifying diagnosis. Absolutely. Shall I tell you what happened?
Please. Yeah.
So, as is the case in acute medicine, we often look after our patients for 24 to 48 hours and then they are transferred to elsewhere. She was discussed with the neurosurgeons who said dexamethasone, as he suggested, to help with that vasogenic edema, but there was no further intervention.
Sure.
She was transferred to another ward, and initially the plan was to do an interventional radiological pelvic collection drainage.
Yes.
This pre-sacral pelvic collection drainage to identify what it was, but actually it didn't happen for a variety of reasons. So she started to get better. A repeat CT scan a few days later showed that the collection had reduced in size. So the plan, therefore, was to just wash away from the collection perspective.
Right.
And the leg weakness was still not being accounted for by the brain changes and the CT head. She was referred to neuropsychology, so liaison psychiatry.
Goodness.
Yeah, and again, very difficult really to identify what the cause is, but they felt that there was probably some underlying psychiatric problem here as well. It's still a work in progress, Ben.
Okay. So summarize like in a couple of sentences.
Yeah, I will try and summarize. I guess this will be with a bit of my thought process in it, but as I was chasing it up recently. So, the unifying diagnosis remains unclear.
Right.
The presentation could be explained by an underlying psychiatric condition, causing functional neurological symptoms in the lower legs.
Right.
That's good, because we've ruled the MRI was normal.
So we're saying that the legs weakness was actually, it wasn't due to an organic pathology or a compression or a neuropathic fibrosis. Yeah, okay. It was due to her not moving her legs.
Potentially, rather than trying to keep searching for. Now, my thought process of Parkinsonism and risperidone was sort of poo-pooped and put to one. So I was like, fair enough. Okay, I take that on board. So maybe I just jumped to the conclusion. But, I'm still thinking the risperidone. But anyway, could it all be due to, did she have a water infection? I don't know. She had a raised white cell count. She had a neutrophil count, potentially. I'm going to throw something else in here, Ben.
Yeah.
Now, when I saw her originally, I spent a long, long time going through her notes and asking questions and all this. For somehow, I don't know how this happens, I missed the fact that 5 years previously she'd had a hemorrhagic stroke caused by. Can you think of anything that might increase your risk of hemorrhagic infarct?
An arteriovenous malformation or something?
She had cerebral amyloid angiography.
No, you meant cerebral amyloidosis.
Amyloidosis. What did I say?
Angiography, which she probably had to diagnose it. Yes.
Cerebral amyloid. Yeah.
Okay. Fine. Yes, that does cause what it bleeds. It causes personality change.
Absolutely. Yes.
It's a cause of dementia. I mean, whose responsibility was it to know that? In your electronic records that you use, does it not throw these past medical history diagnoses up at you when you log on, or no?
No, I couldn't find it on there.
Right.
When I'd gone on to her past records from the general practitioner, for some reason there was very little on there. So I didn't do probably enough deep delve investigating into that as I should have done. Again, time limited probably. How
You say that, but one of my bugbears is people who do a massive deep dive into all the previous medical history for acute presentations. And I'm saying, so what's the plan for this patient? And they're saying, oh, I'm up to 1993 when they had a toenail removed. I'm like, what on earth? They're coming with pneumonia. Come on, focus. This is irrelevant stuff. And if you're going to develop it, you've got to learn how to tune out what's not relevant, what is relevant now. So I actually chastise people who do that. So I probably miss this as well. Not chastise. I'm very lovely, but I would say, well, I think we can refocus our efforts here. Come on, let's focus on what the acute presentation is. But and with our electronic record that we use, the signal to noise ratio for data is really off. You get everything, their life story.
Okay.
So the art of a history has changed from what I learned, which is make sense of what the patient tells you. Now it is try and make sense of this massive autobiographical, every blood test they've ever had, to focus on what's going on now. And I'm very cognizant of the fact that when I was training, if the patient didn't tell you something, then you didn't write it down. You didn't know. If the patient forgot to mention, whoops, I did have a stroke last year, and spent several days in ITU. But they didn't tell you, didn't go in your history. And we were all very surprised later on when we found out. And that was just medicine. Whereas now we have so much of information at our fingertips. The hard bit is what do you leave out rather than what you include. And anyway.
You would not want to do a ward round with me, Ben. You'd be like, Amie.
Focus.
She did grow E. coli in her urine 17 years ago, but I'm not sure that's relevant.
No, I'd have had a word.
I'm not an acute physician. I think I'm a chronic physician.
But this is important because people are listening to two consultants with two different ways of doing things. Who's right? Trick question. We're both doing what's right for us because we figured out what works for us as consultants. And this is why I really do like postgraduate medicine, because you're not trying to make people uniform and do things a certain way. You're trying to encourage people and teach people to work out what works for them and help them do it efficiently and safely so the patients get the best outcomes. And I kind of like that we have different ways of running a ward round because that people can listen. And I don't know going, oh, Ben's way sounds rubbish. I'm going to be a bad consultant because, well, then maybe you're more of an Amie, and that's the kind of consultant you're going to be, and that's great if you can make that work for you, which you do.
Well, and I think over time I've changed as well. So I think as I move on in my career, I probably am a bit more thorough because I'm really worried about missing things, and I've definitely changed when I was an early consultant to who I am now. But also, I think that's being a consultant and a resident doctor, it is, I hate the phrase, but it is a journey, and you are developing into the type of doctor that sits with you, that follows your core values, that follows your morals, and that's authentic to you. And I think that's really, really important. But I could still learn a lot from you on your ward rounds, I'm sure.
One thing I like to say, because I do a lot of teaching for medical registrars, and I say a lot of the training and professional development you undergo as a med reg is working out what kind of consultant are you going to be.
Yeah.
So keep your eyes open. See what's around there. steal the bits you like. We love it. That's it. If you like the way someone does something, you use that. But look for your role models, audition your role models carefully, and then work out what kind of consultant you want to be.
And
Yep.
what kind of consultant you don't want to be.
Don't want to be. Yeah.
Yeah.
So, yeah, negative role modeling is very powerful. People say, I'm never going to do it that way when I'm a consultant. Yeah.
I think that's what they do when they watch me. They're like, oh God, I don't know. I know. I am thorough, I think is the phrase, rather than slow, although I am, which results in me taking time. But anyway, I'm now at peace with that.
Good.
So that was actually that when I reflect on that case now and how we spoke about it, it feels a bit all over the place and a bit disjointed. That is exactly what happened. Medicine isn't A to B. It's A, round the corner, go on the toll road. It's all of these different things that are thrown in at you at different ways. And sometimes it does feel a bit messy and a bit disjointed. And I think that's medicine.
That's a nice example of that. You don't always get the diagnosis on the post-take ward round. Yeah. Sometimes I do write things along the line of, I think there is a diagnosis to be made here, but I haven't quite got it yet, or something like that. But yeah, sometimes it's a bit messy. And I think a lot of our cases we present are wrapped up in a bow at the end. I quite like it isn't, because it's realistic.
Absolutely.
Well, that turned into a bit of a bumper episode, but I really enjoyed the conversation we had. People really getting their value there. And what I'm going to take away from that is you can't always fit. Well, you can try, but it's not all the right thing to do to fit everything into one diagnosis. Because that using what we call confirmation bias, discounting evidence that goes against your clever diagnosis, including the bits you do, like picking things at a buffet, sometimes it really takes you down the wrong road. So I really like the sort of complexity of that case.
Good. I'm glad. Well, thank you to all our listeners out there, old listeners, new listeners. A massive thank you to the Royal College of Physicians of Edinburgh for supporting us. Please rate, review and subscribe our podcast. Thanks for listening. Goodbye.